it's a busy graph, and I'll just try and explain it a bit. What we have seen is that over a period of time, these are three graphs, 2020, 2021, and 2022. So when the pandemic started, just before the pandemic, there was very little, less than 5% of services were delivered via telehealth. When the new items were introduced, then the telehealth rates jumped up to close to 50%. And then it kind of fluctuated over the course of the rest of the year. Then in 2021, it also kind of fluctuated over the course of the year, and it continues to so. The reason why it's fluctuated is because different states were in lockdown for different periods of time. So in some states, people were able to continue to see more face-to-face, whereas in others, they were needing to see people via telehealth. And so it's kind of hovered around this 30% mark, that around 30% of services are delivered by telehealth now that we are. And I think as time progresses, we will see that will probably evolve a bit further, and then give us some more data in terms of how well it is going. As a college, we also put together some telehealth guidelines. We had guidelines previously, and we updated those guidelines. They are available on our website if people are interested. So certainly one of the things which happened during COVID is we were able to reform service delivery and incorporate telehealth at a higher level in our service delivery models. And the other thing which we were all worried about when COVID started was that we were worried that the suicide rates will go up because there was significant job losses, many businesses closed, and people were lost their income. Are very well aware of how things were happening on different parts of the world, people moving back to their homes, and the challenges associated with that. But evidence still now indicate that there is no increase in suicide-related deaths in Australia during the pandemic. And I think, even though there were some factors like job losses, of course, and rates of distress went up, we found that the suicide rate didn't go up, and there are a number of things which contributed to it. One is possibly a sense of we are all in it together, so as a sense of community getting together. There is some data from the Spanish flu in 1920s that during the pandemics the community can get together, and that can be a productive factor. And so that was evident probably during the pandemic, increasing level of trust in others and governments in Australia. The other thing which is important was the role of income support. So there was this job keeper and job seeker income support which was provided to people who lost their jobs. So I think as a result of that, financial issues were less of concern to a lot of people. And then I think we also noticed that through a number of modeling, that as a result of those financial support, levels of poverty and housing stress was a lot less compared to what was there previously. And again, rates of poverty fell down significantly during COVID-19 as a result of those financial assistance people were able to receive. So there is, of course, some research. We are continuing to monitor the impact of pandemic on mental health, and we found that young people and women are more likely to report higher levels of distress. We also will continue to monitor the suicide rates, and we'll see what happens over the next few years. We know that through evidence previously that disasters sometimes can have a timeline, so it can be 2 to 3 years before you start to see some of the impacts of disasters, and so that'll be interesting to see what happens during this period of time. Just lastly, couple of slides. We also focused on a number of well-being initiatives. You all probably know through the media stories how the healthcare staff across the world were under so much of pressure. A lot of psychiatrists of Black, Asian, ethnic minorities in UK doctors lost their lives. A lot of doctors in India and other countries, including Bangladesh, were under a lot of pressure during the pandemic. And so we did some work about partnering with Blacktown Institute, which is an institute in Sydney, about developing an app which supported health professionals. It's a free mobile app which can connect and provide easy access to people, healthcare professionals, and there are some interactive resources. So we did that work during the middle of the pandemic. And the other thing we did was we expanded our website. We got a section on our website, Find a Psychiatrist, and so we encouraged people to identify if they were willing to see other healthcare professionals and provide support to them. And so we added a number of filters to that in terms of availability to provide support to them, whether they could do individual work or group therapy, and of course not charge them for that service they were providing. So we found that many of these things were supportive and helpful to not only for the patients but also for healthcare staff across the sector. Couple of things in the end-to-end. We, as I said earlier, we have a national corresponding membership, and those of you who are interested in joining that membership or want to find out more about, you can go on to our website. It's www.ranzcp.org. www.ranzcp.org. So there's quite a bit of information available there. Many of our resources are available for general public. You don't have to log into the website. It's in public domain, and information about the international corresponding membership is there in that public domain as well. And lastly, we have our annual conference. It's in Perth next year, 28th of May to 1st of June 2023, and there might be some of you who might be interested in attending that conference. And please keep that in mind, and look at our college website. There is quite a bit of other information about various other events as well. I think I'll end there. I've got around 20 minutes I've taken it, and then I think we'll wait for the questions.
My voice is not. Thank you, sir, for your resourceful and informative presentation. If our audience has any questions now, though our question answer session is at the end of the whole virtual session, but if there is any question, then I would like to request you to ask in the head mic. Okay, there is a question. Please pass the hand mic to sir.
Hello. Hello, Dr. Binay Lakra, for presenting excellent presentation. I want to ask, like my experience in India is somehow the role of NGOs are really great, because not only it is not only task for any government or any individual, but NGOs are playing a very great role, especially those people who are staying at railway platforms or those on street, especially the people with mental illness, those who are homeless mental illness people with mental illness. This is a really problem. The role of NGOs are. What about you in Australia or New Zealand?
So is that Gautam Dada, isn't it? Gautam Dada? Yes, I recognize the voice. Nice to see you.
Thank you.
Look, I think that's a very good question. Because people might think developed countries have lots of resources, but when it comes to mental health, there are lots of challenges we face, and we have added significant problem about homelessness in Melbourne and many other major cities as well. And when the pandemic started, there were a few things which were done by the government in collaboration with various organizations who were involved in that space to support and help those people. And many of them actually put into hotels during that pandemic's lockdown period, and they received appropriate support, including food and whatever else they needed. And so eventually, essentially, for a period of time, that issue was quite well addressed. But as the pandemic started to wane off, and people have, and the hotels have opened up and the businesses have returned to activity, many of those homeless people have returned back to the streets. So in some ways, during the pandemic, the governments were willing to actually do something different to address homelessness. And it was also driven by the fact that they did not want the COVID-19 to be spread by people who were homeless, and they make sure that they were also receiving appropriate vaccination. But as soon as the pandemic is stopped, we kind of back to where we were with regards to homelessness. And so there are a number of NGOs and there are a number of programs which focus on addressing issues of people who are homeless. It is on a different scale than what, of course, you would have noticed in India and many other countries. But certainly, I think there was initiative to address that issue during the pandemic, and now we kind of back to where we were before the pandemic. So I think I don't think the government's kind of did much to learn from that aspect. You know, one of the things to learn from that aspect is that homelessness is an issue for many of our psychiatric patients. We know that many homeless patients, up to 50% of them have a psychiatric disorder. And so if their psychiatric disorders are, they receive appropriate support and treatment, and they receive good support with regards to housing, then their lives can change forever. And unfortunately, I don't think the governments in Australia actually learned from that aspect of it in terms of what they could do to address the issue of homelessness.
Thank you, sir. Thank you so much for your beautiful answer. I'd like to request our audiences to write the questions down, and at the end of the whole session, we'll take the rest of the questions. Now we are moving on to the next presentation. Our next speaker is Professor Danuta Wasserman. She is a professor of psychiatry and suicidology at Karolinska Institute, Sweden, and the current director and founding head of the National Center for Suicide Research and Prevention of Mental Ill Health, NASP, at KI. She is the president-elect of the World Psychiatric Association. She has a pre-recorded session with us, so I would like to request the technical hand to present her pre-recorded presentation. Thank you.
Dear colleagues and friends, today I will speak about COVID-19 pandemic and the influence of the pandemic on mental health and suicide. But firstly, I will present myself. As you know, I am the president-elect of the World Psychiatric Association, and my mother institution is Karolinska Institute, where I am the head of the National Center for Suicide Research and Prevention of Mental symptoms, increased anxiety, depression, but also fatigue and distress, and especially in older adolescents, especially in girls, and in children and adolescents living with neurodiversities and chronic physical conditions. Risk factors for those young adolescents and young adults were living in rural areas, having low family socioeconomic status, being a family member or friend to a healthcare worker. Of course, healthcare workers had more time maybe to pay the same attention to the household and children in the household. Increased social media use was also a risk factor and school closure. But the protective factors, on the opposite, was social media use included good communication with peers and including positive and cheering up activities online, social and family support, positive coping styles, access to entertainment, physical exercise were other protective factors for those young people. And the results for suicide-related emergency department visits were similar as for adults, non-conclusive. For example, from France in Paris, we can see both decrease during the first lockdown period and later on 100% or 200% increase of visits to emergency departments. We have also similar results for California. What happens with suicides and during the COVID-19 pandemic? First, some basic epidemiological facts. Around 700,000 suicide deaths worldwide is estimated to occur annually. And global suicide rates were decreasing since year 2000. However, suicide is still a prominent leading cause of death for young people and adolescents between ages 15 to 29 years of age. For each suicide, approximately 20 persons attempt suicide. And the global standardized suicide rate is 9 per 100,000 for the total number. For males is higher, almost 13 per 100,000, and for females lower, 5 per 100,000. But it varies between different continents. So for example, if you look at Africa continent, males are very high suicide rates, and also in Europe. But when you look, for example, in Southeast Asia or Western Pacific, the differences between females and both sexes are not so big, but the males are prominent on each WHO, in each WHO region. As I mentioned before, suicide is the fourth leading cause of death in young people, 15 to 19, and also 15 to 29 age. And among females is the third leading cause of death, and among males the fourth leading cause of death after traffic accidents and different kinds of injuries. Risk factors for suicide we can characterize as modifiable factors, which means those who have psychiatric disorders, social isolation, poor lifestyles, poor coping strategies, are unemployed with financial difficulties, poor housing, with poor family and relations, many conflicts, school dropout, access to lethal means of suicide, have risk factors which we can modify to treatment and preventive strategies. But what happens during the COVID-19 pandemic? We can see that in most investigated outcomes were suicide rates and self-reported suicidal thoughts and behaviors. And in a paper published in 2021 in the Lancet Psychiatry by the consortium, big international consortium, we can see that in 21 high and upper middle income countries, suicide numbers have remained largely unchanged or declined in the early months of the pandemic compared with the expected levels based on the pre-pandemic period. These results were followed up for more months, for a longer follow-up period, and the results were the same. However, there are some country-specific or even within the same country, region-specific differences. So the suicide rates did not decrease in Hungary. In opposite, in relation to the previous results, they increase in all age groups. In Spain, we have the highest suicide rates for all ages in the country's history. And suicide rates increased in adolescents as well as in France, and especially during the period when children came back after closures of schools, when they came back to schools and maybe were targets for similar risk behaviors with bullying, etc., as before. In Poland and Japan, there was an increase in females. In India, increase in males. In Brazil, increase in elderly and in poorer regions. In the United States, increase in Hispanic males, Afro-African individuals, and Asian and Pacific Islanders. But the general picture was that there was no increase during the COVID-19 pandemic. And the question is why? Of course, we all know that there were massive economic stimuli from governments in almost all countries. There were regional stimuli in healthcare systems and concerning housing situation. Also, individuals received paychecks in some countries. We know also that there was increased use of digital services in treatment and prevention, as well as in communication with significant others. There are reports and papers showing that during COVID-19 pandemic, use of alcohol and drugs diminished in many countries, that family were more cohesive and did more positive activities together. We know also that increased awareness of healthy lifestyles and compliance to them increased. For example, physical activities, even in very small stages, WHO had many advices what to do and how to cope with that. Dietary habits, sleep advices, and advice about other health behaviors were massive, and probably people were complying to those advices. We know that the prevention and treatment of suicidal behavior can be performed from the public health approaches perspective or healthcare perspective. And now I will go through very quickly through those evidence-based approaches. When we look at the pharmacological treatment, we know that antidepressants, lithium, and antipsychotics are very potent preventive medicines in suicide prevention. But we know also that pharmaco-epidemiological studies show more positive results in comparison with single randomized controlled trials, mainly due that much larger samples are involved and we have a longer follow-up periods and also maybe less stringent participant exclusion criteria. When treating suicidal people with antidepressants, we must be aware that during the first period of treatment, there is increased anxiety and suicidal urges. Therefore, we need to combine antidepressants with psychotherapy, but also in some cases with anxiolytics, and have a very active follow-up of treatment and possible side effects. Ketamine, there are studies now showing rapid decrease of suicidal ideation, but we need, of course, more studies to look at the long-term effects, safety, etc. Lithium, as I mentioned, is a very potent anti-suicidal medication when compared to an active control and when compared to placebo or non-specific interventions. The same is for
presentations given by two dignitary respected teachers. Thank you. Please pass the hand mic to sir.
Well, thank you very much. I must congratulate that both of the presentations were very relevant and very appropriate, specifically looking at the COVID, post-COVID, and the COVID links to the mental health. I think the first presentation was giving a lot of hope, a lot of insight, and thanks to Vinay for giving an excellent view about what has happened in the developed world. Of course, there are many things which we can learn from this, but at the same time, we would really like to have more involvement of NGOs, of non-government sectors, and the patients and the carers. Regarding the second presentation, Professor Danuta Wasserman is an expert in suicidology, and as she has been mentioning, there has been mixed results of the COVID about increase, decrease, or no change in the suicide. I think during the post-COVID period, probably we will be getting more insight and we will be able to know that how can we increase the protective factors as well as modify some of the risk factors.
Thank you so much, sir, for your valuable feedback. Now, I would like to request Professor Wajul Alam Chaudhary, sir, to give his feedback.
Thank you. So, at first, I would like to congratulate both the speaker for their wonderful presentation. Rather, I should say, very worth listening presentation from both the speaker. I also offer my heartiest thanks to the participants, those who are actually very patient to hear the presentations. Our first presentation, Ravina from Australia and New Zealand. So very wonderful data and information of their government as well as their many NGOs, particularly the telemedicine is a very important aspect of total support. During the COVID time, actually you can't help people directly, but at least telemedicine became a very important alternative or option, and they have done it very nicely, successfully. We in our country also tried, but they have done whatever they have done, it is really praiseworthy. One thing Dr. Vinal mentioned that during COVID, the feelings like we are all together. It's a very important thing. During any disaster, people must have these feelings, this conception that we are all together. So I definitely remember the famous song of Paul Rock, "We are in the same boat, brother." So really wonderful feeling, and we must remember this during any crisis. So regarding second presentation of Wasserman, is a very beautiful presentation because a lot of papers he has brought together. That's meta-analysis of very important data and papers from global, rather I should say global presentation, though we had very time constraint, but I'm very eager to hear from her more information regarding different mental problem during COVID and what happened with suicide. So really, I am very glad to congratulate Dr. Wasserman for her wonderful presentation. She has mentioned what happened in case of with suicide during COVID-19. Actually, in our country also, the risk factor and the vulnerable groups almost all the same. But in our country, we have found that the people, elderly people particularly, they had been in a very poor, bad situation because the whole family, particularly the early part of the COVID, when total population was very anxious, rather they jeopardized total mental energy. During that time, our elderly population was really very in trouble. Anyway, we have just somehow overcome the situation. But one thing is very important, I think, is although we are telling about the post-COVID, but actually this is not a totally post-COVID situation. COVID is slowly rising in some region of the world, even in our country. During the last 3 or 4 weeks, it is gradually rising. Anyway, we must be careful about the situation. I would like to offer my heartiest thanks and gratitude to both the speakers. Thank you very much.
Thank you so much, sir, for your valuable feedback. Now we are at the very bottom of this virtual session 1. Now it's the crest giving time. And now I would like to request Professor Muhammad Gulab Rahmani, sir, Chairman, Neurodevelopmental Disability Protection Trustee Board, to provide a crest of honor to our respected chair, Professor Afzal Javed, sir. Sorry. Sir, please come to the stage and receive the crest. স্যার এখানে চলে আসলে মনে ভালো হতো ডায়াসিসে Thank you. Now I would like to request Professor Syed Mahfuzul Haq, sir, renowned psychiatrist, former director, Pabna Mental Health and ex-head of department, Chittagong Medical College, to come to the stage and provide the crest of honor to Professor Wazul Alam Chaudhury, sir, President, Bangladesh Association of Psychiatrists. Thank you, and this is the end of our virtual session 1. I would like to give my heartfelt gratitude and thanks to the respected chairs and the speakers. Due to time constraints, we could not take much questions. We're really extremely sorry for that. And last of all, I would like to wish you a very good day. Today, the first day of the scientific conference, and heartfelt gratitude and thanks to Bangladesh Association of Psychiatrists and Obscenene for being here with us in this first virtual session. Thank you, and signing off, Dr. Sumaya. God bless.
Thank you.
Distinguished participants, honorable international guests, respected teachers, and ladies and gentlemen, Assalamu alaikum, and a very good afternoon to you all. I am Dr. Mohammad Shakawat Hussain, working as a postgraduate trainee at the National Institute of Mental Health, Dhaka. On behalf of Bangladesh Association of Psychiatrists, I would like to welcome you all to our virtual session 2. For this session, we have 2 chairs. Our honorable chairs are Dr. Gautam Shaha and Brigadier General Retired Professor Muhammad Azizul Islam. I'd like to request them to kindly take their seats. To introduce our chairs, Dr. Gautam Shaha is the President of SARC Federation of Psychiatrists and is the founder director of the clinic Brain Neuropsychiatric Institute and Research Center, Kolkata. Professor Brigadier General Retired Dr. Muhammad Azizul Islam is a professor of psychiatry and currently the principal of US Bangla Medical College Hospital in Narayanganj, Bangladesh. He is also the serving Vice President of Bangladesh Association of Psychiatrists. We are going to have 2 very renowned speakers for our virtual session 2. Our first speaker is Dr. Adrian J.B. James, and our second speaker is going to be Professor Helen Herman from Australia. Are we connected to the first speaker? Ladies and gentlemen, we are waiting for the connection to our first speaker. Please give us a minute. Since we have finished the earlier session a bit early, Our session was scheduled to start at 3:35, so we haven't yet connected to our first speaker. I would like to request for your patience for another 3 or 4 minutes. Connect first. Ladies and gentlemen, we still haven't connected to our first speaker, Dr. Adrian. I would like to request your patience for another few minutes.
Hello?
Ladies and gentlemen, I think we have Professor Helen Herman with us. She was supposed to give the second presentation, but since we have her online, we are probably proceeding with her presentation. To introduce her, I must say that Professor Helen Herman, AO, is Professor Emeritus of Psychiatry of Origin and the Center of Youth Mental Health, the University of Melbourne, Australia, and the Director of World Health Organization Collaborating Center in Mental Health at Melbourne. She is the former president of World Psychiatric Association and the International Association of Women's Mental Health. She is going to present on the topic of Time for United Action on Depression, a Lancet WPA Commission. With the kind permission of the chairs, I would like to request her to start her presentation. Professor Fellow, please carry on.
Well, thank you very much, dear colleagues. I'm delighted to be with you and just sorry that I'm not there in person to appreciate your company and the Congress. I'm pleased, as mentioned, to talk on this topic and I will talk first briefly about global mental health and the context for the report, and then talk about the Commission in terms of preventing and treating depression and the whole of society engagement, and overall our role as professionals, our role in strengthening community responses to mental health needs. And I will end on considering how prevention is critical to reducing the burden of depression. So thinking about global mental health in terms of improving health and achieving equity in health, it's part of, and really the topic was introduced very effectively back in 1995 with the publication of the book World Mental Health, led by Professors Leon Eisenberg and Arthur Kleinman at Harvard Medical School, the problems and priorities in low-income countries, and looking at this cycle of social disadvantage. And they particularly looked at the question of the importance of relative social disadvantage, that not only absolute poverty or exposure to violence, but the position respective to others in the same community, but also the particular risks inherent in chaotic neighbourhoods, in city slums or in rural poverty, settings of rural poverty, and the discrimination, violence and exclusion that went with those, that present high risks for mental ill health, and they in turn present additional barriers to health and livelihood. So that while it remains important to make sure that our role in supporting the treatment of mental ill health is important, we need also to pay attention to the social and economic conditions of life for people. And the Lancet Commission on Global Mental Health and Sustainable Development was published in 2018, led by Vikram Patel, also from India and Harvard Medical School and the London School of Hygiene and Tropical Medicine. And this reframes mental health and considers nature and nurture across the life course and their interaction, and the importance of mental health as a fundamental human right for everybody, whether or not affected by mental ill health, and also most particularly for those living in conditions of adversity and deprivation. And of course this is highly relevant to life in Bangladesh, where many people are displaced and people exposed to climate emergencies as well as other adversities. So in terms of global mental health, this commission expanded the agenda from reducing the treatment gap that had been an effective focus for work on global mental health before that. There had been a lot of work on looking at how shared care and collaborative care could be effectively implemented in low-income settings. And the agenda included this, but it was expanded to the promotion of mental health through considering how environments can be made conducive to good mental health, as well as to the prevention and treatment of ill health. And also reducing the burden of mental and substance use disorders by addressing what was seen as gaps in prevention, as well as gaps in the quality of mental health care, particularly the human rights treatment and the reduction of coercion in mental health care, and extending the scope of treatment to include social care. So there was a particular set of messages from that commission that included the fact that there are cost-effective solutions to mental health care, and that it's a large part a matter of political will and the resources that flow from that, and the ingenuity and the engagement of mental health professionals alongside and together with communities. And bearing in mind that mental health can be improved through sectors beyond the health sector, including education, urban planning, justice, family welfare. And the third message on the bottom left, that mental health varies together with education. So good education and good mental health go together. Reduction of gender discrimination goes with good mental health. Reduction of poverty alleviation goes together with good mental health. And climate action is consistent with good mental health. Now, along with that report on global mental health, we had the WHO's Comprehensive Mental Health Action Plan that was extended recently to go to 2013, so introduced in 2013, and it already had said that the objectives for global mental health include strategies for promotion and prevention, as well as those for providing comprehensive and integrated health and social care services in community-based settings. Another report of high relevance is Time to Deliver. This was a report of the World Health Organization's high-level commission on non-communicable diseases and mental health. And that particularly pointed out that by including mental health in programs of prevention, treatment and care for health, so that mental and physical health worked together, was there were evidence-based advantages in doing this. And then, most recently, in July this year, we had the report, the 20th anniversary report from the World Health Organization of the first World Health Report on mental health. And this emphasizes that business as usual for mental health won't do, and that mental health is an integral part of general health and well-being, and its role as a basic human right. So on this background, I'll tell you a little about this Lancet WPA Commission and how we came to the title, Time for United Action on Depression. This was published in February this year, and it's available free of charge from the Lancet's website, particularly the website section that is devoted to commissions, and you can see the full report of the commission as well as infographics that support this. So this commission began work almost 5 years ago now, and Vikram Patel and Christian Keeling from Brazil joined me as co-editors, and we had in total 24 commissioners from all continents, various parts of the world, and it was a wonderful collegial group and a brains trust, and it included people who were from disciplines of psychiatry and psychology and primary health care and epidemiology, economics, public health, and others. And we were very well supported by the Lancet editorial staff, including Richard Horton, who really urged us onwards to make sure that the public health view was included in this report, which was very much our own interest. So the funders are acknowledged here, and those that supported our meetings. And the support from the Wellcome Trust and UNICEF for two young people who, with lived experience of depression, they consulted with us on the proposed recommendations as they were being developed. And the opportunity to consult with people with lived experience more broadly on the recommendations before the final publication. We were supported by United for Mental Health, the global mental health peer network led by Charlene Sunkel, and the Service Users and Carers Advisory Group from the World Psychiatric Association. So we began work on this full of enthusiasm 5 years ago to advance understanding of the nature and causes of depression and to put together evidence on prevention and care and identify knowledge gaps and recommend actions to promote public understanding and thereby prevention and care globally. And so we began with the concept that if we look at the global burden of ischemic heart disease on the top red line here, this illustrates a decline in that burden over the last 30 years. And I think most of us are aware that the decline in health burden from ischemic heart disease can be attributed in part to advances in treating heart disease. In fact, these have gone ahead very well supported over time in many countries. But the great change in burden and great change in prevalence has come from public health measures such as smoking cessation, changes in diet supported by negotiations with food industry and food producers, and changes in opportunities and recommendations for exercise among the populations. Of course, this is uneven across the world in countries, particularly Europe and North America and Australasia, that where smoking cessation has been a focus, and some of these other measures, the prevalence has declined much more dramatically than in other countries. But some of the major Asian countries where smoking prevalence has even increased, these changes are not seen. But unlike the changes in heart disease and the other non-communicable diseases, including cancers and lung diseases, the global burden of depressive disorders, the prevalence has not declined over this time. The burden of disability related to depression increases sharply in the second and third decades of life in countries of all income levels. And you'll see the high-income countries in the pale green at the top, but most of the burden, along with most of the world's population, is in countries of low and middle income. And while the increase is sharp in these early decades of life, we're also familiar with the idea that disabilities and related to depression accumulate over the life course in those people that experience further episodes or persisting illness. And the impact of COVID-19 has been significant. Recent publications, including in the Lancet last November, illustrated that it's very likely that the burden of depression has increased by at least 25% in the early phases of the pandemic, and most likely continued since then. So depression and psychosocial adversity go hand in hand, whether it's poverty in slum settings, as mentioned earlier, or in displaced populations or after disasters, or related to child maltreatment, that depression is a cause and a consequence of psychosocial adversity. And depression kills, as illustrated poignantly by John Steinbeck. And also, as clinicians, we're familiar with the fact that people living with depression die prematurely, not only related to depression, but also because of high rates of comorbidity with other physical health conditions, including heart disease and stroke and cancers. And most people with depression, whether in high or low income countries, still receive no care or inadequate care. But the pink bars relate to low and middle income countries, where the contact with services may be as low as 1 in 4 people with living with a diagnosable depression or someone with a condition that could be improved with treatment. And the likelihood of adequate therapies being received are as low as 1 in 8 people in high-income countries in the blue column, and the very short pink column on the right is the proportion of people likely to receive that treatment in low and middle-income countries. But the former Prime Minister of Norway reminds us that stigma is the main problem, and that myths about depression, such as depression is the invention of the biomedical industry, or it's culture-bound, or it's a personal failing. These prevent people coming for treatment as well as prevent others in support for them when they do. So the first understanding was that interventions at multiple levels are needed to reduce the burden of depression globally, to address that public understanding and political will, and to drive prevention at different levels, at societal and individual levels, as well as access to effective care.
Professor Helen, if I may interrupt you a little, we're at the end of the stipulated time for you, so I would like to kindly request you to finish quickly within 2-3 minutes.
Okay. Well, I didn't realize that, so I think that's okay. That's fine. We started a little late, but I'll finish. So it's a common health condition. It's universal. It's been present over time. It comes in many forms. Prevention is the key, whether it's societal levels, addressing poverty, gender discrimination, in various settings, in families, at schools, looking at school climate, looking at social and emotional learning, autonomy, physical activity in workplaces, addressing loneliness in neighbourhoods, and working with vulnerable groups, those exposed to violence or bereavement. But particularly this work on violence in families, as well as the evidence we have about individual and family interventions across the life course. Their experiences are unique of depression and recovery. We need a formulation. Those of us in clinical work understand this very well, and we can build this in even to shared care settings. This is a most important endeavour that we thought a lot about in the Commission, and you can read about it in the report. A staged approach to care with prevention, early intervention, and treatment and care, ranging from those with early first episode or pre-diagnostic anxiety or depression, and recurrent and persistent depression. The early intervention idea, of course, originated in psychiatry, in psychosis, but it needs to be more fully considered in relation to depression. The way that effective interventions can be introduced has been thought about carefully, particularly by Pim Karpers and Toshi Furukawa and colleagues, and you can see that in the report. And the extensive evidence that exists about closing the care gap and engaging people with lived experience. Collaborative delivery models, people with lived experience in the centre with their families, and the shared care, cross-sector providers, mental health specialist teams, and the primary health care teams. So it's whole of society engagement and translating what we know into practice and building the evidence-based. So we had messages for each of the four audiences, for the general community, including those with lived experience and their families, about seeking support early, not being put off by stigma, talking with others, remaining hopeful. We present the evidence that most people do recover, as in any health condition, even though we continue to see those who have recurrent or persisting illness much more frequently. And focus, asking them to focus on their own priorities and speak up for societal changes. For health practitioners, including those in primary health care and ourselves, be proactive, learn about the diversity, the personalisation of care, prioritise the therapeutic alliance and recognise its power, and practice that collaborative care, seek ways to do that. For researchers, particularly looking at prevention as well as treatment and developing precision medicine approaches, this is becoming much more of a focus and needs to become so for depression. And engaging with the people who have experience of depression and their families and the practitioners and policy makers, and for the decision makers, respond to the lived experiences and the science. Invest in tackling inequities, early intervention, as well as sustained care, the scaling up of the task sharing of the psychosocial interventions, and investing in research. And investing, we provide tables and information about how depression prevention, care, and achievement of several of the Sustainable Development Goals from the United Nations go hand in hand, including number 3, good health and well-being, number 5, gender equity. And I mentioned this prevention, message on prevention that I'd like to emphasise, and how there is extensive evidence, but we need to be building it through local action and assessment, development, understanding that there need to be mental health outcomes measured in relation to evaluating interventions in family, school, and other sectors. This publication from the National Academies of Medicine in USA in 2019 is especially useful in terms of the examples and the evidence it provides. So it's a message of hope. The Commission synthesises the evidence on what can be done to prevent and care for depression, how they can be implemented even in poorly resourced contexts, at least in terms of material healthcare resources, and integrated with the wider health and social systems. It may well be the task in Bangladesh as elsewhere to make sure depression care is well integrated with primary health care, and that we as professionals find effective ways to work with the leaders of the primary healthcare professions to train their trainers, and in turn to have them train the community professionals or community lay people who will work there. And that it's only by united action from all these audiences for this report that we can transform mental health globally. Thank you.
Thank you, Professor Helen Harman, for your insightful and wonderful presentation on depression, especially the aspect of prevention. Now, if we have any questions for Professor Harman, please write it down, and we will discuss the questions in the discussion session after the presentation of Dr. Adrian. So, do we have Dr. Adrian online?
Hello, and it's really great to be with you. Can you hear me and see me?
Yeah, Dr. Adrian, we can hear you and we can see you, but let me first introduce you a little bit. Our second speaker today, Dr. Adrian J.B. James, he is presenting on public mental health and pandemic, a UK perspective. Dr. Adrian is the elected president of the Royal College of Psychiatrists. He was elected in 2020 and he has a term up to 2023. Dr. Adrian is the consultant forensic psychiatrist at Langdon Hospital in Dawlish, Devon. Now I'd like to request him to present his topic. Dr. Adrian?
Well, thank you so much. I'm absolutely delighted to be invited to the Bangladesh Association of Psychiatrists 11th International Conference, and I'm so sorry that I can't be with you in Chattogram. And thank you to Mohammed Alam for the invitation, of course, your President, Professor Chowdhury, and I'm really honoured to be in the presence of Gautam Sahar, a long-standing friend, and of course Brigadier General Professor Islam. Thank you so much for inviting me and for putting this session on. I believe you've got my slides and you're going to show them, and I'm going to talk about the pandemic and mental health. Is that right? Have you got my slides ready to go? I might be able to access them myself. Are you going to put the slides up?
Can we put the slides up from here?
I believe
The permission is given, Dr. Adrian, you can slide share from there. The permission is
I'll
given.
see. Do that. I'll give you
We can see your slides.
Okay, is it, have you got that in the right format? Is that all okay? So, okay, so I'm going to talk about public mental health and the pandemic, the UK perspective. As has already been said, I'm the 47th president of the Royal College, and I'm actually getting towards the end of my term. Actually, time flies, really, doesn't it? And I'm also a frontline clinician, and that's really important to me, that I'm still working within services. I experience the same challenges that everybody experiences, and staff. and our Office of National Statistics show that an estimated 2 million have been experiencing long COVID. There's hopeful evidence as well that it would appear that for most people, this is not going to be a lifelong condition. That most people, that the symptoms resolve within a year. So that's a good thing, but that's a long time to be struggling. I think probably all know people personally, maybe some people actually watching today who are still struggling with the long together users and carers, public health experts to promote public mental health as an intrinsic part of psychiatry. Often people have not seen prevention as being core to what we do as psychiatrists. We're there to treat illness, but surely our most important role is, where we can, to prevent mental illness. Looking at high quality evidence and advice and recommendations and support mental health needs assessment at a national level. So a whole variety of things that we're doing. So that's all I wanted to say. I hope that you can see the slides clearly and that you could hear what I was saying. But we've got a long way to go. But we must keep trying, and some hope actually. I think one of the things that makes me most hopeful is when I meet with my colleagues, like surgical colleagues, as in the Royal College of Surgeons, or to the physicians or the general practitioners, that they recognise the mental health need. They're very supportive. There hasn't been any sort of downplaying of mental illness or of our college. In fact, they've all been really supportive of making sure that we get those messages about mental health out there and that they are prioritised. So thank you for listening, and I hope you enjoy the rest of your amazing conference. So thank you for inviting me.
Dr. Adrian, for your beautiful presentation. Now we will move to the discussion session, and if our participants have any questions for the speakers, we'll take the questions now through our chairs. Did anybody submitted any written questions for the speakers? I don't think we have any questions, so we'll move on to the discussion session. And for the discussion session, I would like to request our Honorable Chair, Dr. Gautam Shah sir, to give his comments on the two speakers and their presentations.
Thank you. At the outset, I must give compliments to Professor Helen Herman and Dr. Adrian James, for both of them, for excellent presentation. In fact, they covered very elaborately and everything they covered. And what Dr. Helen Herman spoke on the time for united action on depression, a Lancet WPA Commission, which is very good move from WPA itself, and I think there are lots of things she discussed and throw lights how to combat depression and what are the points we should take care all worldwide, and it is a great help to all of us and throwing such light. Thank you, ma'am, for excellent presentation again. And after that, Dr. Adrian James, who spoke on public mental health in UK after the pandemic, in fact. And it was also very fascinating, and you know that so practical things he mentioned, especially in the long term. The UK made a rapid guideline which is needed not only all the countries we should take care, because he mentioned that almost 3.1% of the population of UK suffered from it. I think if you study in our countries also, maybe the more, because there are lots of cases which includes not only physical but also mental health problems. And definitely the suggestions are very well accepted, like collaboration, promoting the mental health and narrowing the need of the inequalities of not only in the treatment or diagnosis purpose but also in the research purpose, because it will throw the future lights how to combat. Yes, pandemic is over, but still the complications of the COVID, especially in the field of mental health, it is really there, and we should take care as a psychiatrist, as a mental health workers, we should take care, but it is not a responsibility of single profession or any individual. We should do it with together along with the government, along with the media, along with the NGOs. We should all together, we should plan and fight against. And also mentioned Professor Helen Herman, the stigma, fighting against stigma, it is most important in this period. In fact, the COVID pandemic opened our eyes regarding the mental health issues, not only in the mental health professionals, but also those who are in the politicians, those who are the administrators. They are also now giving importance on the field of mental health. Thank you.
Now I would like to request Brigadier General Retired Professor Dr. Mohammad Azizul Islam Said to say a few words on the presentations.
Thank you very much. Indeed, it's a very pleasure for me to be here with the Dr. Gautam Shah, President, Psychiatric Federation, as the co-chair. At the very outset, on behalf of Bangladesh Association of Psychiatrists and on behalf of me as Chairman Scientific Committee of the International Conference of Psychiatry, I want to express our heartfelt gratitude and thanks to the two great psychiatrists, two great leaders in the field of mental health who has accepted our invitations and joins here with us in the deliberation of their speech. Ma'am and sir, we are really grateful to you and we really are honored for your presence and for your presentation. I am very small two comments on the paper they presented. First of all, the Professor Helen Herman, the subject was very timely demanded subject, time for United Action on Depression. It is really fact that it's the time to work unitedly on the depression, not only on depression, it's time to work unitedly throughout the world for the mental health cause. Because not in the Western countries, in our country also, or in the developing and developed countries also, the focus are the same, areas are the same, the problems are the same, and probably the preventive strategies will be the change. The challenges we are facing all together, we have to work unitedly. That's the main issue. And ma'am, you have focused many points. I'm really amazed to see all these points over there. And I will advise and I will tell my students here or from the Bangladesh psychiatrists from Bangladesh and neighboring country to follow what you have told. And Dr. Adrian, sir, we are delighted to be here with you. Your presentation, we have a very strong fascination for the Royal College. Royal College of Psychiatry, we think a great thing. As you are joining with us, we feel very delighted. And the topics was public mental health and the pandemic UK perspective. Actually, you have given all the ideas, mainly focusing on the UK perspective, but the focus is for the world also. And many of your comments, on the 8th February, the comment 2022, the comments you have given is very much important for all of us. And what is there important for the country like us? There is scarcity of funding in the government level, in the private sector. There is inequality everywhere. Inequality in the mental health services, inequality among the peoples, inequality among the services, among the doctors and whatnot, inequality in the professions. What we need, we are also trying to work out on the awareness building, the promotion of the mental health for the people of the country, for the people who are very distressed in the country like Bangladesh. People are really neglected, the people of mental ill, they are really neglected and we are working for them. We want your help in the days to come, and we believe that if your great people remains beside us, we will be working together. One important point only to note here, that like you in the countries, we have also have the Mental Health Act in Bangladesh, which has been came into the parliament and passed in the parliament in the 2018. And we have the mental health policy and mental health strategic plan from the government. This government of the present government of Sheikh Hasina, Prime Minister Sheikh Hasina, she is more or less, I will say, the friendly for she feels for the mental health and mental health causes. And the Bangladesh Association of Psychiatrists has been working relentlessly for all these activities. Please provide the support in the days to come. And thank you so much for your presence with us.
Thank you, Brigadier General Professor Mohammad Azizul Islam, sir. We will now take our leave from our speakers. I would just like to say that Bangladesh Association of Psychiatry will